But welcome to the Retain It webinar series on solutions for achieving surgical and restorative success in the Edentulous mandible. Our presenter tonight is Dr. Matthew B. Hallis, founder-owner at Bay Lakes Center for Complex Dentistry. And with that, it is my pleasure to introduce Dennis Urban, NDX DSG's Director of Clinical Education. Take it away, Dennis.
All right. Thank you, Jessica, and thank you, everybody, for joining us tonight. We're excited about part 3 here and welcoming Dr. Hallis back for the Retain It series. And last week, Dr. Hallis covered identifying cases for implant overdenture therapy and implant surgical protocols, including complications and how to overcome them. So it was some great relevant information. And Dr. Hallis has lectured on dental implants, planning, placement, and restoration protocols and procedures throughout North America. And tonight on part 3, Dr. Hallis will be continuing the Retain It series with the in-depth information, including case selection and the utilization of many dental implants and restorative options and protocols. So with that, I'm going to take it away, Dr. Hallis, and welcome. And we look forward to part 3.
Perfect. Thank you. Thanks for joining us again on part 3 of the series, as he said. As most people are probably returning, they know who I am already, but we'll just give a quick, brief overview. Where I trained, what I did. As I said, I am based in Green Bay, Wisconsin. I have a practice that is focused on pros, and how I ended up in Green Bay from that whole history of New York to Chicago to ultimately Green Bay was because of fishing, and there's not many prosthodontists that fly fish with their wives. So that's kind of what brought me to the great Midwest. I'm fortunate. I have a busy pros-specific practice that we focus on complex rehabilitations. We have a referral-based practice. This is what I want to see tomorrow morning when I'm in the clinic doing a new patient exam. I want to see train wrecks, collapse bites, full arch reconstructions, utilizing implants. That is the niche that we focus on, and I'm fortunate to do that. Okay? I like using implants. I like creating smile transformations, how we blend the parts, the pieces, and the materials together. And as I said before, I am a huge believer in if you're not providing implant treatment, you're not providing the standard of care. There's not a day that doesn't go by in our office that we're not using an implant for some type of restorative option. Okay. What's important, as I've mentioned multiple times before, everything I show is what I use in my office, what we do in our office. I'm not paid to use any of these products. I'm paid to speak. I'm sometimes paid to evaluate products, but I am not paid to use them. If there was a better product, I assure you I would use it. Everything I show you are my cases today and what we do on a daily basis. Okay. Prior to COVID, as I said, I used to force you to see our vacation photos. Now things are finally returning to normal. It kind of feels nice. We're taking a road trip in a week down to get our hunting dog. Our little 5-year-old is really excited. Unfortunately, last year we lost our dog. So this year we have skipped the diaper phase, and I bought a trained hunting dog. So he's really pumped. As Dennis said, you're joining us for part 3 of the Retain It series. Part 1 was diagnosis and treatment planning. Part 2, we focused on conventional implant placement. Part 3 today is a little unique. Okay, we're going to talk about the history of mini dental implants. We're going to talk about case selection and utilization of mini dental implants for provisionalization in that transition stage. And then we're going to talk about the surgical and restorative protocols, how I use them during this period. And then obviously post-op, we got to manage these cases. Okay, today is going to focus on a unique spin on mini implants and how I co-utilize them with conventional implants. Okay, part 4 and 5. Part 4 is going to talk about restoring these cases that we've talked about in diagnosis, treatment planning, placing the conventional implants. We're going to talk about attachment selection, what is available, clinical techniques of picking them up, attaching them to the denture, and then management of complications. And then ultimately, we're going to talk about integrating things into your practice. I'm a big believer. If you don't commit to doing it within a week of the course, doing it, finding patients, you're not really going to integrate it. You got to get your staff involved. And so we're going to talk about that as well. As Jessica said, there are questions. We'll take 10, 15 minutes at the end of the lecture today. If there are additional questions, there's nowhere really to go, so we can spend a few extra minutes. Happy to answer questions. Dennis is managing them. If there's something pressing, something that's not understood, he'll jump in. So with that, let's kind of look at this. Let's review back from lecture 1. Edentulism, very common. 30 million people in the US are edentulous. That's true edentulism. 2011, the first baby boomers turned 65. 90% of denture patients are unhappy with the fit of their dentures. I really believe in that kind of statement, and that's something we have to think about, right? Remember what I said was, what is the functional capacity of a patient with a denture and overdenture? You know, in my opinion, an overdenture is a standard of care, but there's a time period between when we can place the implants, let them heal, give them that temporary denture, then create the final denture. That takes time. And depending on patients' lives, are they snowbirds? We have issues. And ultimately, there's patients that have just conventional dentures or avoiding the dentist because they have heard that dentures are uncomfortable. And as I said previously, the changing face of edentulism is the soon-to-be edentulous patient. This is where I focus on using implants, where I focus on using the mini implant technique that I'm going to show you today, where a patient has avoided the dentist for 10, 12, 15 years, does not want to be without teeth, does not want, you know, something moving around, still wants to go out in public, okay? So this is something that is incredibly challenging, though. We have to assess and address how we're going to transition them from a terminal dentition to their new dentition.
Put $100 at the entertainment center. Let's go to work. We're supposed to go out to eat on our anniversary. When I came home, the $100 was gone. He was gone for 2 days after that. And when he came home, I asked him what happened to the money because he didn't know what happened to it. Oh, so you might wash it off?
You can see here the teeth.
So as funny as that is, we have to think about why a patient has avoided the dentist. What are their fears? Is it fear of losing their teeth? Is it fear of dislodgement, unable to eat something in public? Is it a fear of impressions? Why are they stressed, emotionally afraid of the dentist? And we have to assess this, okay? Now, this is a big question, and this is something that I deal with in my practice on a daily basis. What do you do when you have a patient who wants an immediate solution and will not wait for months, who maybe is financially constrained, cannot afford the immediately provisionalized fixed restoration treatment plan? So how do we address this issue? They want to have something that's going to function, that's going to give them stability, give them confidence, but they can't afford the fixed implant all on 4 type treatment, okay? Classic patient. Terminal dentition, severe periodontal disease. This is what I want to see in my office. Come tomorrow, new patient consult. What do we do here? What are the challenges? Take all the teeth out, put 2 implants in, let them heal 4 months, then start the restoration. Takes us another 3 months, then adjustments. Ultimately, you have 8, 9 months of treatment, right? At the end, they're very happy, but that transition phase of taking the teeth out and letting them heal is challenging. So how do we address that window? And how I do it a lot of times in my office is enhancement of overdenture therapy utilizing mini dental implants, okay? So let's define what a mini dental implant is, okay? It's a small diameter implant, typically less than 3 millimeters, and it's a 1-piece design is what I'm referring to when we talk about mini implants, small diameter implants, or MDIs, okay? Let's look back at the history, because there's a lot of misbeliefs and misunderstandings with MDIs, okay? So the use of MDIs began when 1.8 millimeter pure titanium, smooth surface, transitional small diameter implants were placed to support fixed provisional prostheses during the bone grafting and osseointegration period for conventional dental implants. In the 70s, a provisional implant was introduced in the form of a loose screw. Excuse me. Some years later, primarily surgical specialists started placing these 1.8 millimeter transitional mini implants to help restorative dentists provide a more stable interim prosthesis. So they were placing 4, 5, 6 conventional dental implants and then 3 or 4 of these transitional implants. These implants were often used without any specific guidelines or protocols, and MDIs were frequently placed between conventional dental implants and immediately loaded with some type of provisional prosthesis. These transitional implants would be removed once their temporary purpose was fully served. This treatment modality has led some clinicians to believe that small diameter implants are for transitional use only. Okay. In 2003, the U.S. Food and Drug Administration approved MDIs for long-term removable fixed applications. Okay. MDIs have been successfully used to stabilize removable prostheses at a relatively economical cost. Today, MDIs are made of titanium alloys for increased strength, roughened surfaces to promote osseointegration, similar to conventional dental implants. Okay? So what is available? What's the history? There's the Morris Sterngold in 2.1. There's the Interlock in 2.0. There's the Park Lou in 2.0. Typically, we're in the 2 millimeter range. There's a 1.8. There's a 2.1. There's a 2.4. Usually under 3 millimeters, as I said, is what's considered a mini dental implant. The main advantage of the mini dental implant is the minimally invasive single-stage implant placement procedure. That's important as we start talking about this. The insertion of the implants does not require raising of a flap and full-depth osteotomy, where the technique involves a pilot hole and placement of an MDI through turning. Okay? Bleeding and post-operative discomfort are usually reduced and healing time is shortened. This is important as we start looking at the technique, because I need a technique that is going to be simple, efficient, okay, easy, and not going to add a lot of time to my conventional dental implant placement. So when we look at this, and we are starting to decide conventional implants versus small diameter implants versus both, okay? There's some people that use small diameter implants for final restorations, and that's fine. I personally don't do that in my practice. I use conventional dental implants in combination with minis, and that's what I'm going to show today, okay? But when I started looking at all this and I started looking for different options and how I'm going to do it, I have to think and make sure I'm not going to compromise the conventional dental implant plan. So the first thing I started looking at is, what is the osseointegration pattern of a mini dental implant compared to a standard? Okay, so mini dental implants are becoming increasingly popular for rehabilitation of edentulous patients because of several advantages. However, there's a relative lack of evidence on osseointegration potential of the MDIs. So the study involved 18 3M MDIs and 18 standard implants were inserted randomly in the tibias of rabbits. Animals were sacrificed after 6 weeks of healing. Both implant contact was measured. All implants were osseointegrated. Okay? There was no statistical difference in the osseointegration at 6 weeks between the MDIs and the standard implants in rabbit tibias. And based on these results, it's concluded that the osseointegration of MDIs is similar to that of standard dental implants. Now, when we start looking at load considerations, and we got to start thinking of strength, okay? And there's concerns, right? What is the length? Is this going to break during the healing stage? How am I going to take this out if I am removing it for traditionals? Is it going to break when I try to remove it? Okay? Because of their reduced diameter, it is logical to question the ability of MDIs to withstand occlusal load. A finite element analysis was completed to assess the fatigue life of 2 millimeter diameter implants and found that the mounted in rigid support and under a cyclic horizontal force, the implants fractured after more than 1 million cycles. So well over 5 to 7 years. Song studied that the effort of implant diameter on fatigue strength found that controlling cyclic horizontal forces was paramount for long-term clinical success of the MDIs. Surgical placement of MDIs is typically minimally invasive as compared with conventional implant surgery. And that's part because we're going to be using a pilot drill. We're only drilling partial way, and then we basically have a self-tapping implant. The insertion of the MDIs needs a minimal disturbance of the periosteum, thus osseointegration process is accelerated and time needed for MDIs tends to be considerably smaller than regular dental implants due to the less injurious insertion procedure. Now, I'm going to show a slightly different procedure because I'm placing conventionals and we're going to have a full flap. Okay? So the integration is going to be a little affected. At the end of the day, I am only looking for 4 to 6 months of service ultimately. I'm not looking at 10, 15, 20 years of service life on these MDIs. Survival rate, okay? Full lower denture, best type of bone, 95% survival rate. Upper denture, decreased survival rate, 83%, Part of that is due to the type of bone we're typically in. Okay. Do I use these on the upper? Yes. We actually use them more often on the upper when we are doing significant grafting cases, such as bilateral sinus lifts, zygomatic cases, where I got to protect the load on the bone, on the implant interface. Okay? The rate of survival attributed to the minimally invasive surgical procedure approach with preservation of the periosteum and endosteal bud supply. Now, mandibular overdentures retained by 2 mini implants, a 7-year retention and satisfaction study. Okay, this is important. We're doing these procedures to enhance the patient's satisfaction during the most troubling time when we remove their teeth, we put them in a bulky provisional with a healing site and have to let them adapt and go and function. So in this limited sample size clinical study, the results indicated that after connecting mandibular overdentures to 2 mini implants, a patient's satisfaction significantly increased and the retention significantly improved during the 7-year observation period. So where are indications for mini dental implants? Stabilizing a complete denture, orthodontic anchorage, single tooth replacement, fixation of surgical guides for definitive implant placement, and more importantly, okay, where we look for it, transitional implants for support of interim removable prosthesis during the healing phase of final fixtures. This is where we use it in our practice. I use it with my oral surgeon in combination if I'm not placing the implants and he's doing the surgery, if I'm placing the implants. This is our key area where we focus on and what we're going to talk about tonight. Okay. Immediate mandibular complete denture that will be loose following the completion of extractions of veoplasty and conventional implant placement. Okay. The key and what I'm listening for is the patient is embarrassed to eat or laugh in public. We don't want them avoiding people for 7-8 months as we go through this treatment. They're concerned about stability and their chewing force. Okay? Happy patients refer patients. Happy patients call you less, right? So let's look at this. We have an upper lower extraction case. We have multiple implants in this case. But I have a challenge here because we had to stage this case. We have to place implants. I don't personally immediately load my zygomatic cases. I think it's a risk. You know, it's a personal choice. But I have a case that we're doing multiple veoplasties on. How am I going to protect all of these implants and transition them through this? And how I do that is by placing mini dental implants, picking them up with soft liners, sometimes using their housings, okay? And we're going to find out how we do that and look at the protocol for a combined implant placement of conventional implants with MDIs. So everything in the consent form is the same. I do inform them about the conventional dental implants and the difference with the mini dental implants. I do let them know that I plan to take them out. If they do integrate and the patient doesn't want them removed in the mandible, as long as they're not in my way for the final prosthetics, I will leave them. I do talk to them about if I do remove it and I do snap the head off, okay, which we will talk about, and it's integrated, it's not infected, I leave that, okay? I don't go chasing it. So all of those are added to my consent form, and I clearly define that I am placing conventional dental implants for the final restoration, and the mini dental implants are to enhance the healing phase of the provisional to increase the retention and stability. Surgical medications are all the same as last time. Nothing changes from last lecture. Anesthetic is the same. Lidocaine, Marcaine, appropriate needles, okay? Nothing changes. The only thing that's going to change is about 7 minutes of adding these implants and then a few minutes on the Reline. So we typically have a patient, as we said, and we're going to assess the patient the same way. Our conventional dental implant placement, amount of reduction, considerations of the floor of the mouth, keratinized tissue, interocclusal space, nothing changes, okay? There is nothing that's going to change in terms of that diagnostic workup. All the mini implants are doing is acting as an enhancement for vertical retention and stability. You got to know your anatomy. It becomes critical because I'm going to show you the positions that we are going to start using. What anatomy in the mandible did we have to worry about? The mental framing. The mental framing, okay? So when we think about this, I'm going to be placing our implants. Where did we talk about our key space for placing the implants last 2 lectures? Lateral incisor as anterior as possible to minimize that cantilever. Now I need to find spacing around there. So that means I'm going to be distal to those implants. I need to know where the foramen is. I need to know where the anterior loop is. How much vertical height do I have? Is there a mandibular undercut that I have to think about? Because we have to start thinking about what lengths of mini implants I'm going to use, what diameter I'm going to select. Okay. So as I said, inferior alveolar nerve, cortical border, mental foramen, okay? Our safety zone, right? Where we're placing our implants. We need to know the loops, okay? You need to know exact dimensions of loops. I'm doing these freehand, I'm not doing these guided. That adds more time and considerations to think about. So we just have to identify where the foramen is. Okay? If I can't palpate it, if I think I'm gonna be close to it, I expose it during the surgery. Okay? I assess the alveoloplasty just like last time, nothing changes, okay? Just because I'm placing minis doesn't mean I do less alveoloplasty. You still need the same restorative space for your conventional dental implants, okay? We always are going to finger palpate the ridge and make sure that that anatomy that I'm seeing on the CT scan matches to what I'm seeing in the mouth. I want to feel for lingual undercuts. I want to feel, is there a knife edge residual ridge? Do I have to think about my incision design? Do I need to make sure that there is not a dehiscence somewhere or thin tissue? Can I feel where the foramens are and identify it and compare it to what I see on the CT scan? Okay. As I said, we talked about the true implant system last time. I'm going to use the same system. We're going to place the implants, okay, in the same steps like we discussed last time. Once the implants are placed, I then find positions for the mini implants. I do not compromise the conventional dental implant sites for the minis. You have to think of final, short term. The final and long term are your conventional dental implant system. The short term and solution solving problem is the mini dental implants that are transitional. So that I can't stress that enough. You don't compromise the sites for your conventional dental implants. I place those first and then I work around them. Okay. When I place them, we do the same thing that we talked about last week. We use a surgical guide. I have a reduction amount that is planned. As we said, I typically like 12 to 15 millimeters of planned interclusal space from my planned incisal edge to the planned implant platform. Okay, we have to accommodate for the locator, stern snap, whatever housing system you're using. Okay, then you need acrylic space, metal framework. All of a sudden, that space gets very small very quickly. We need to make sure we're not too lingual, we're not too buccal. We got to be in the center of our planned prosthetics. Okay. From there, as I said, my key implant sites are typically the mandibular lateral incisor as anterior as I can get it. The further posterior you go, you create a seesaw rocking motion that we want to avoid. Okay, so there, we've placed our implants, we've flattened the bone. Now we're ready to begin the temporization phase. Okay, nothing changes. Put your cover screws on, and now we have to think about where are we going to place the implants. Conventional protocols tell us we need 4 mini implants in the mandible, okay? But that is the long-term restorative protocol for MDIs. So we have to decide how many do we need, where do we need them, can I fit 4 in there in between the implants? That would be tight, right? We got to look at the space and we got to look at the interforaminal space. Okay? So when I start looking at this, I look at where are my conventional dental implants. Now, where can I add implants? And if I think about a tripod support, that's what I'm going to design. So I'm going to put 1 in the center, okay, somewhere in the midline, and I'm going to put 2 distal to my terminal implants. Okay, it'll give me a good tripod support. It's going to keep me in that safety zone. I'm going to have enough room to stay away from my conventional dental implants so I don't compromise the bone support. And it's basically set up like a fixed implant case in terms of spacing. When you look at that, okay, you have to think about spacing. We always must have 3 millimeters of bone between implants to maintain the crestal bone height. It's nothing different than I do in my fixed implant cases. I don't do a lot of 5 implant fixed cases. I do a lot of all on 4s typically. in our practice, but the concepts are the same. We are trying to create a AP spread to support our final restoration. Okay. In this case, we're trying to design an AP spread to retain our provisional restoration. Okay. So as I said, I can't stress this part enough. Your placement order is conventional implant placement first, then we do the MDIs. Okay. The instrumentation is simple, and this is key and critical when you're assessing a mini dental implant system. You need a simple system that is not going to add a lot of time to your procedure. If you think about it, I just completed extractions, a veoplasty, 2 implant placement. Now I have to add some mini implants. I'm already flat, the patient's already numb, the kit's out. It should not add a lot of time. If you're already planned on your spacing, you have your surgical guide, this should be smooth and efficient. We're then going to be able to suture, and we want to have a procedure and a mini implant system that allows for a quick, efficient reline. Okay. So in this kit, we have a torque wrench. We have some type of implant driver. We have a pilot guide or pilot drill that's going to allow or facilitate placing the mini implant. Okay. So the protocol here using the MDIs from Sterngold, okay, is a twist drill, okay, not drilled to depth. We have to think about the length we're going to use, how deep we're going to drill. If you're placing a 13 millimeter, you typically drill to about 7. Okay. We then have some type of hand driver. I like the initial hand drivers. I personally use the wing driver more than the knob. I feel I have better grip with it, but you can start with whatever you like. Okay. Or I like using the implant motor. What we have to consider with mini implants, okay, is the length that we're going to use. And we have to think about designing and achieving initial implant stability. This becomes critical to allow you to immediately load and functionally use these implants. You have to have a stable implant. So we're going to choose the longest length as the bone allows that will allow for a minimum amount of primary stability to be achieved. We want all the blasted threads should be engaged in the bone. The collar here, hopefully you can see my mouse, needs to be bone level, and that's going to allow the tissue to heal around, and then your ball attachment is going to allow it to be functionally picked up and retain your temporary denture. The bone on the micro threads and the soft tissue respond well to the soft threads. Okay? So what do we have available? What do we use in our office? What don't we use? What do we typically select? Okay. So in this line, okay, you have 2.1, 2.4, and 3.0 diameters. Okay? The 2.4 is an emergency bailout. If you're trying to do a conventional 4-implant protocol and did not get one of the 2.1s stable, I have not personally used the 3.0s, okay, in my practice. When we use them, I'm typically using 2.1s in 13 and 15 millimeter lengths in the mandible. Okay, I have not really used an 18 millimeter as a transitional implant. I would probably use that as a conventional implant system if I was going to do this as a conventional long-term. I like bigger or longer implants, as I said in my initial lecture last time. Okay. The 10s I use if I'm approaching a loop. Okay, so I do keep a few 10s in my practice in case there is an anterior loop that I don't want to be approaching. I have to think about removal of these from time to time. I also use them in the maxilla when we're in the sinus or around the sinus. I don't want to be engaging these through the sinus because you can end up having one migrate into the sinus and then you have to go get it. Okay. So the general rule, each implant should be surrounded by 1 to 1.5 millimeters of bone. Okay, the 2.1 is the standard thread for D1, D2, 2.4 and 3.0 are for D3. Those are really designed for the maxilla, okay, or a bailout if you did not get initial stability with the 2.1. Okay. It has a minimally invasive protocol, so you drill 7 millimeters. We start with the initial driver, then you use the wing driver to begin slowly advancing this half turn at a time, allowing the bone to expand. You cannot just drive this in at 60 newtons straight down. It will not allow the bone to expand, and you can actually overheat the bone. Okay. From there, you're going to use the final torque wrench to seat it and verify you've achieved the minimum torque. Okay. I like 35 to 50 newtons, okay, just like on my implants. When we look at the length, and this is an important slide to remember when you're beginning to select lengths and what we have to do, you have to get all of these threads engaged in bone. So you have to get the micro threads and their macro threads intraosseous, okay? You have to get all those threads engaging bone. The smooth collar portion is just like our working punch portion. The ball attachment has to be above the tissue. If you have done multiple extractions of vealoplasty, you are going to have excess tissue. You may have to tissue punch around these to get that clear. Okay, you have to have a good suturing technique and reapproximate the tissue and get it bound down. Okay, your denture is then going to hold the tissue down, exposing these, because once we engage them. So things that we have to think about, but you need to get all the threads engaging bone. Okay. As I said, we're typically using these in the anterior mandible. So we're going to be using type 1 and type 2 bone in most cases. Okay. Torque wrench, torque wrench. Okay, you need to use a torque wrench to ensure you have achieved a minimum resistance of 35 Newton centimeters. Ideal insertion torque is 35 to 55. If you're under 35 and you're going to immediately engage this and load it, what ends up happening is you end up getting fibrous encapsulation of it. It fails to integrate because you don't have enough bone to implant contact, and they're just not stable enough. So you need to have 35 to 55. Do not really go over 55 as you run the risk of potentially breaking one of these, okay, as you're engaging it down, okay? So first question I always get from people, is primary stability a requirement for osseointegration? Absolutely, okay, it's essential. Micro movements lead to fibrous encapsulation. We have to think of the osseointegration process, right? The initial 8 to 10 weeks is mechanical stabilization. As the osteoclasts and osteoblasts move in, break down bone, re-encapsulate that implant in bone, we have osseointegration occurring from the 10-week mark to about 4 months. That's our secondary implant stability. Okay, that's the remodeling process. So primary stability is mechanical. That's your initial stability, your initial torque. Okay, we need good bone implant contact. You need good stability. You can't have an implant that's in at 10 Newton centimeters. Then we're going to try to functionally pick it up, have the patient engage and eat on that. The implant will be out in their hand the next week. Okay. From there, what it looks like fully seated. This is a healed edentulous ridge, fully seated. I am not working in a fully healed ridge, and we're going to show what that looks like on a case. So this is my classic patient where I would use a combination case of conventional dental implants with mini dental implants. So I know I will need an upper and lower denture, but I am not ready for both at once. And we have to think about this, and everybody has this in their practice. Some patients I can stage. And by stage, I mean I can treat the upper, not compromise my final upper restoration, then treat the lower, and then get everything to blend and match together. Other cases, unfortunately, I have to tell those patients, I'm sorry, I have to treat both arches. It's all or nothing, okay? And you have to be, as a clinician, astute enough to assess and decide when I can pull this off, when I can break it up, and not let the patient drive what they want, okay? That's something that's critical, is understanding what we can achieve, and that is truly possible, okay? So we have a 59-year-old female patient with a history of type 2 diabetes, high blood pressure that's currently controlled, dental history, 10 plus years, with a maxillary mandibular RPD, phased treatment plan. So there's a lot of information here that's important for when I am treatment planning a patient. A patient, okay, and I get this question a lot. How do I decide when I am going to offer and tell a patient you really need a fixed restoration versus an overdenture? Okay, so a patient that is happy with a mandibular RPD, okay, has had a mandibular RPD for 10 plus years, that is stabilized by anterior teeth, is typically not going to have any concerns transitioning to a conventional denture that is supported by implants. Now, patient that has struggled with the partial, has not worn the partial, you can clearly see the wear patterns, okay? Super eruption. Those are not patients that are going to do well with an overdenture, and you need to consider doing a fixed restoration, okay? So, took the upper teeth out, lower partial, upper temporary denture. Let this patient transition, calm down from taking out all of those teeth. She knows her lowers are going to fail. when they're going to fail. She's going to let me know there's no infection. Okay? It's not compromising anything. Now we have to start assessing space. Where are we going to put the implants? Okay. She's concerned about not being able to eat, not being able to function, have her lower denture flop around. She does have a large tongue, right? When we start assessing the space, remember one of the criteria I told you in diagnosis and treatment planning is mobility of the floor of the mouth. How much is that going to rock and cause fishtail motion of that denture? Is the tongue enlarged posteriorly? Is it going to compromise your denture flanges where your tooth position is? Okay. CT scan is taken, plenty of bone. We have to look, are we going to do some alveoloplasty? Where is the foramen? Where is the inferior cortical border? Okay. Is there undercuts? How thick are those cortical plates? Can I take these teeth out? Alveoloplasty past those defects? Are there infections? All the things that we've talked about previously. We're going to proceed with taking the teeth out, placing our conventional implants, flattening the bone, completing the alveoloplasty. And now we have to think about the provisional phase. Okay, so what is the protocol? How do we move through this? So as you see back here, we have a flap, we have bone positions that we have to think about. Where did I tell you? We have to kind of work around our conventional dental implants. We need 3 millimeters of space. I like a little more than 3 millimeters of spacing because I have to think about if I do need to remove one of these, if I do have a problem, I do not want to affect my conventional dental implants. So first is your mini dental implant pilot drill. The whole idea here is to perforate the cortical plate. One thing you have to remember is I did do alveoloplasty. I have a lot of cancellous bone, so that is going to go through that bone relatively quickly. We're going to use up and down pumping motion. It's the same drilling action, same drilling method as our conventional. A full depth osteotomy is not part of this protocol. I can't stress that enough. A full depth osteotomy is not part of an MDI placement protocol. Drilling. Okay, during the process, you have to be careful. It is just like placing our conventionals, not to angulate. The path you drill is the path that implant will go in. You also have to remember this is a self-tapping implant. So when we place this implant, we have to place it at the path that we want. You have to be very careful because I do not feel implants that are angled have good engagement and function well. From there, the package is basically the same. We're going to peel back the cover, open the inner blister pack, okay? After we've drilled, and as I said, if we're placing a 13 millimeter implant, I typically drill to about 7 millimeters, okay? I may have to drill a little more if there's too much bone, we'll talk, or too much torque, we'll talk about that. I would increase it to 10. It's always simpler to have a smaller hole and need to go to a larger hole or longer hole than to go from a longer hole to a shorter hole, right? From there, we're going to make sure we engage, okay, the implant. You have to make sure you have a clear engagement. It's not dropping out. I like to hold it upside down, engage it, and then bring it to the mouth, but you got to make sure you're not going to drop it, okay? In many cases, the implant can be fully seated using the Moore wing driver. So you initially use the screwdriver here to insert it using the insertion tool. You take a few turns, okay? You're going to start feeling resistance. Once you feel resistance, you are going to switch to the Moore wing driver. This allows you to generate more torque as we insert, okay? These are self-tapping implants, okay? The key here is the word slow down. When the torque wrench is necessary, the bone is very dense. Thermal trauma can be created through friction and could either fracture the implant or cause bone damage. The implant is auto-advancing, as I stated. We have to avoid lateral forces, which can cause uneven torque. It also can cause misangulation of your implant. So when we're doing this and we're driving that implant in, we take a half turn, let the bone expand. Take another turn, let the bone expand. If you're using the torque wrench or that wing driver, don't automatically just start cranking 2, 3, 4, 5 turns. You have to just slow down, look at where we can engage, how much we're doing. And I like this. Take 7 seconds for each quarter turn. Okay, count in your head. Wait 5 to 10 seconds or more between turns. This allows the bone to dissipate and expand. You're going to do this until the implant is fully seated. Okay? Until the implant is fully seated. Remember, the ideal torque range is 35 to 55. Okay? The use of the thumb or forefinger of your opposite hand to apply downward pressure to the head of the ratchet or torque wrench during this use. This will limit lateral forces. You have to understand a torque wrench. You can't just grab it from the shaft and start going. You have to use two hands and really stabilize this torque wrench, especially if you're taking a quarter turn waiting. As a dentist, I'm very impatient, and most of us are, and we want to kind of get through this. You have to slow down on this part. Okay? The implants are fully seated when all the threads are engaged in the bone. Okay? As I said, we place this under flap procedure. Make sure your threads are there, and then I can move this around a little bit. The apical tip of each implant is stabilized by the cortical bone, or the implant has reached optimal torque resistance. The ideal height of the prosthetic platform of the restoration will then be achieved. Now remember, extractions, alveoloplasty, excess tissue. So this is what I want to see on the day of surgery. I want to clearly see each ball head. If I can't, I will thin some of that tissue down with either a tissue punch or my surgical blade. Okay. We're going to modify, okay, the restorative protocol. So we are going to do a direct restorative protocol the day of surgery. Okay, and then we're going to modify this about 10 days to 6 weeks later. So in my protocol, once the implants are all placed, suturing is done. Suturing was the same as you saw in this past picture. Okay, a few single interrupted sutures, maybe a couple continuous interlocking, and life is good. Okay, day of surgery, I do a conventional soft line using CoSoft. Okay, it engages some of the head of the implant. It gives enough stability. I don't relieve it over the heads of those ball attachments. Okay, most people are going to be sore. They're swollen. They want to leave the operatory. 10 days to 6 weeks later, I will typically go back. I will trim out the soft liner premolar to premolar, and I will pick up the retention caps using the easy pickup. Okay. So, day of surgery, we use a burr, create recess and retention relief. Okay. You got to make sure the denture fully seats. Okay, you got to make sure it's not hanging up on those ball attachments. If it is, you got to relieve the denture. From there, I reline the area with CoSoft. Okay, I use CoSoft material. I don't like using the CoComfort, which is the white one. It is too soft and it tears. The CoSoft does not tear, it doesn't rip, and it just seems to create a better long-term result. Patients also like the pink. Relieve the denture, as I said, drill out the area, pick it up, and that's what it's going to look like. Okay. Take your scan, x-rays, make sure the patient's comfortable, trim your soft liner, and say, see you later. Okay. 10 days to 6 weeks later, I will see the patient. My defining time when I will pick up the RC1 caps is when the patient is not sore enough for me to be able to snap the caps on and then use the easy pickup to pick these up. If I touch the tissue and the patient jumps around, the tissue looks friable, it's still irritated, then I will come back in a few weeks and pick these caps up. Or if the patient is complaining the denture is really moving around, I may numb that patient lightly in order to allow me to facilitate working around the tissue and pick these caps up. It allows for greater retention than just engaging the ball attachments with the soft liner. Okay? As I said, I use the easy pickup. I like this because it's odorless, it's pink in color, and it doesn't set with heat. It's not really affected by moisture. It sets up well, it's strong enough for this procedure, and it's just a clean, easy to use product. Remember, it uses its own bonding agent. It is a dual cure, so it's able to cure with the light and by time. It has a quick setting time. It's quite frankly an easy pickup material to use. Okay, you got to have the area relieved, so I go back and I will trim out the soft liner. I will apply the Vantage varnish to light cure that, and then we apply the easy pickup. I do use vent holes. So one thing you will have is you will have sometimes excess height on these because I am not placing these under a flapless condition. So positioning the ideal height sometimes becomes a challenge. Sometimes the tissue heals back further, and now these MDIs are a little higher than you like. Any undercuts, I use rope wax to block them out instead of the donut O-rings. Okay? Place the caps, make sure the denture fully seats and it's relieved. Okay, you've applied your varnish, and now we apply the easy pickup. I then trim, contour, shape. I leave the black O-rings in there. That's the typical ones I use. Make sure it seats down, the patient is happy. Okay. This is something that is a game changer, and I've done this quite a while. Patients that have a stable temporary that they are able to reasonably function on with modifications in their diet, as I've talked about, a modified soft diet. If you can cut it with a fork, you can eat it. They report significant increases in retention, comfort, and chewing ability. It's a big change. And if you have a happy patient, you have a happy practice, right? Healing time is the same. I typically wait 4 months, okay, for all of my conventional dental implants. As I said, I have a smoker, I have soft bone protocols that I used. I did a lot of grafting. I'll probably wait 5 or 6 months. Now, stage 2, 4 months later, implants are placed, MDIs are there, patient comes in, we uncover the implants, okay? Uncovery is the same as I talked about last lecture. Numb the patient up, expose the implants, place the appropriate size healing abutment that is going to match up to the attachment system that you're going to use. You relieve the denture in that area. I leave the MDIs at this time. The MDIs stay through the final fabrication procedure. Now, when I start moving to the final procedure, and I'm beginning the fabrication and I start impression, there are analogs that I can impress both the conventional implants, their snap system, and the MDIs. If the implants are fully integrated and stable, like you are seeing here, there's bone to the top of those microthreads. I don't see any reason why they're going to compromise my final restoration. I sometimes leave them. Okay? Other times I will take them out if they are in the way of the attachment system, if I have too thin of acrylic. Okay? If the patient is indifferent and doesn't care, if they're going to go back or they're traveling, I will probably take them out because I don't need them for additional retention. Okay? In order to remove them, we'll talk about this coming up when we go through the final restoration. I normally just back them out with a torque wrench. You do run the risk sometimes if they are fully integrated, you have a long 13 or 15 millimeter implant, sometimes they break off at the neck of the bone here. If there is no signs, symptoms of any type of radiographic problems, I leave it. I don't go chasing it. I don't treff it out. If I needed to, I would trephine it out, but that has been very rare and far and few behind, and I can count on one hand how many times I've needed to do that. Okay? After that, we schedule the patient for impressions and we start moving to the final restorations. Okay? To me, this is a game changer in terms of stabilizing the provisional restoration for the patient with a very simple procedure that does not add a lot of cost or time to that stage. As I said, references, like last time, Dental Atlas of Implant Surgery, fantastic book, picture book of doing all this stuff. Surgical Implant Complications, I like that book. It has a lot of information on complications in both surgery and restorative dentistry and how to address and fix them. And then ultimately, the Journal of Pros, Complete and Removable Dentures, talks about what's new, what's different. So with that, I'm going to see if there's some questions. We have about 10 minutes or so to take questions. That concludes part 3. Next week, we will do part 4, which is going to be attachment system design and selection, application, why I choose a ball attachment versus a locator versus a stern snap, how we choose the heights and measure them. That's one of the biggest mistakes I see. And then ultimately how we decide between the direct and indirect pickup methods. Do I impress them in my final impression? Do I not? Do I register them? Do I have the lab process or do I pick up? What type of framework design do we use? So that's what we're going to go through in part 4. That'll be next week. So is there questions, Dennis?
Great. Thanks, Dr. Hallis. Yeah, if anybody has any questions, we have the Q&A box on the bottom here. Just click on that and ask your questions. And great information, Dr. Hallis. I had to just comment on the easy pickup material. It's so much better than years ago when we were using self-cure acrylic and things like that. And patient had a taste monomer and had used to run, sometimes lock things into place. And especially years ago with like hater clips and hater bars, self-cure acrylic, I used to get these panic calls at the laboratory. What do I do? There's nothing much you could do but cut it out, but great material, we utilize that for even chairside conversions, but good material there. I also wanted to comment, you were talking about the analyzing the size of the tongue before. And what I try to get across to our technicians is that, if we can get information from the doctor on if it's an enlarged tongue, we make those adjustments in the denture and make them contour that lingual of the denture to accept the tongue and maybe create a little bit more room. Because I've seen a lot of dentures where it's really thick on the lingual and it limits it even more with the space of the tongue. So,
we use the Sorensen's border paste.
What was that?
We use the Sorensen's border paste.
Oh yeah.
If I end up missing that, right, kind of what you said, and I don't contour it in the wax try-in.
Right.
One of the things we do is we do apply that paste because the tongue it almost paints it on the border.
That's good.
Start contouring with our burrs. One of the burrs I use is in our electric hand piece. It's a pineapple zirconia burr.
Right.
I like those for contouring acrylics because they cut and polish at the same time. It doesn't.
That's great.
Like carbide. So that is something that when we adjust, and if I do feel the denture is lifting and they're moving their tongue and they try and they say, hey, I feel constricted, we instantly get out the border paste. I bring it up to the teeth. I have them go through the motion, lift their tongue to the top of the mouth, move it out to the sides and then forward. And I start seeing where we need the contour. I mark it with a pencil and I take it in the lab and I trim it using that zirconia burr first. Then I use those, I don't even know what they are. They're the denture finishing burrs. They're kind of almost like foam.
Right.
Those the polish, and then I final polish on the lathe. And that usually prevents me from having to send it back to the lab.
That's good. Good technique. I like that. I like that a lot. That's great. Good information. Well, we're waiting for some questions from you guys. Yep, I think somebody has a question. Okay, yeah, here we go. What is your favorite Reline material? I think you answered that before.
For that, I use for most of the attachments that we pick up, if I'm picking up the RC1, the stern snap, the locator, I use the easy pickup. The main thing is using the bonding agent and putting mechanical relief inside your acrylic as well with like a number 8 round burr. I don't rely only on bonding. I follow the same concepts when I do my composites and my crowns. If I'm doing conversions, if I'm doing bigger pickups, I actually don't use the easy pickup. I typically switch to the mucohard. I find it's a denser material for bigger spaces. If things are confined, I use the easy pickup day in, day out. The problem with the mucohard is it sets with heat and you got to be very, very careful with it.
Yep. Yeah, good point. When you're doing a reline, say if you're doing a locator reline, and do you remount the existing caps and just seat new housings in there and take an impression over those, or do you keep the original housings with the attachments?
So if I have a denture and I'm doing a lab process reline,
right,
I will actually just impress the locators and have the lab put relief, and I will do a chair side pickup.
Gotcha.
The last thing I want to do is take those champagne hourglasses, drill a giant hole in the denture, and then either crack it, compromise it, or give you guys more work to do. So
Great.
In those cases, I don't send the caps. The caps I find create a awkward loading. I like doing a reline in a passive reloaded tissue state where I have them bite down, we've captured the borders, and go from there.
Great, good technique. So, all right, I don't see any more questions here.
Fantastic.
All right, I think let's see, we're at 7:55. Give it another second here. Any questions? Any more questions? I don't see any. So, well, I think that should do it. Thanks, Dr. Hallis. Great presentation. And oh, yes, one just popped up here. Here we go. If you're planning on using MDI for long-term retention, how long do you recommend waiting after the extractions? Yeah, so let me read that again. If you're planning on using MDI for long-term retention, how long do you recommend waiting after the extractions?
So what I would end up doing in that case, so if you're going to use, instead of doing an MDI, instead of doing a conventional dental implant, you're going to do an MDI case, I would remove the teeth. I would alveoloplasty so the ridge is parallel and flat, okay? I would let it heal 4-ish months usually, okay? What I'm looking for is I want a flat ridge with stable tissue. I would then go back and do that case in a conventional protocol, flapless, so I can position each implant at the right height, and I would use 4 implants. So that's how I would do that, but I would typically wait 4 to 6 months. Usually it's about a 4-month wait. Some people can go in at 3 months. The problem at 3 months is I do find there's always that little tissue change, and that could end up kind of screwing you on a one-piece implant that you cannot change out the locator heights or stern snap heights. So it's good to be a little more patient.
Great, thanks. Thanks, Jeffrey, for that question. And also we have a question from Charlize. Which method would be the ideal method for processing implant dentures? Pouring, injection, or packing? I know I have my version of it, but let's hear what you have to say, Doctor.
We use injection molding.
Yeah.
Pretty much, pouring that's for like flippers, in my opinion. Packing is what I did in my pros residency. Because I wasn't brave enough to injection mold and screw up all my work, right? There's a lot easier. But if you were to ask me to pack a denture now, I would laugh. I think injection molding gets rid of, what's the new system? Say they get down to residual monomer of less than 1%.
Yeah, Ivabase is a great system. Also, Ivabase is good. It injection cures at the same time. That's a great system also.
Yeah.
And it's injection, and injection, you have constant pressure from the acrylic onto the ridges, so you have minimal shrinkage. So it really works out well.
The other thing we do is we're doing a lot of digital based printing and milling. I think that's the future.
Yep.
Part of it is trust in your lab techs. I work with a couple techs that I trust exclusively. I have had a long-term good relationship with them, and I will talk to them and find out, hey, what do you think here? On a high, deep palatal vault where you think you're going to have a lot of shrinkage, we might go to mill dentures right now. On a broad, wide ridge. I think injection molding does a really good job. It's been proven. So I let the technicians decide at some point too, and if there needs to be a conversation or a worry, that's where we talk. You can see if you start doing injection molding versus a printed, it's amazing how little of a post dam we need with the digitally printed or milled.
Right.
It almost kind of makes you take you back a little bit, right?
Yeah.
And if you do put too big of a post dam, I've noticed you get significant sore spots.
That's correct. And I've been hearing the same thing, especially on the mill dentures too, in the post dam area, with either reducing or we have recommendations from the various companies saying you don't even have to put post dam, but I like to put some sort of post dam in there,
We beat ours, almost like a partial, because I do feel you get, you have at the vibrating line, you have a compressible area that you got to kind of think about.
Definitely. And even on the, we talk about digital dentures, some of the attachment systems out there now, they have scan bodies. So we're utilizing the scan bodies and actually milling or printing our denture bases and having the doctor pick up the attachments intraorally in the office. So it's good. We're coming a long way. It's a continually evolving technology, which is exciting. It's exciting. So we have another question here from Rima. What is the minimum amount of millimeters would you use for provisional implants? What is the minimal millimeters?
I'm assuming that's the length and then the width. So in the systems that we use, the oral surgeon has a 1.8 millimeter implant. We use the 2.1 in this office. As I said, it's rare that I jump to a 2.4 or the 3.0. I don't even think I stocked the 3.0s here. I can't even remember the last time I placed one. That's almost borderline going to a conventional dental implant. As far as the minimal length, it would be the 10 millimeter over the foramens or by the sinus. I prefer the 13s and the 15s. I normally place the 13s And if I can't get that stable, I will drive in a 15, slightly longer.
I see. Great. Good. Let's see if I'm seeing any questions here. I think the time we're at the 8:01 point here, so I think we're good. Yeah. Any other questions? I don't see any other questions in the chat box here. From Rima to all panelists, thank you so much for a great presentation. Thank you, Dr. Hallis, and thank you everybody for joining us tonight. And be sure to stay tuned for part 4 next Thursday at 7 p.m. But another great presentation, Dr. Hallis. Thank you so much. Appreciate it.
Guys, have a good night. Have a good week.
Yep. Have a good night. Take care.
Bye.